Welcome everybody. I'm Dr. Brian Buchanan. I'm from the University of Alberta, Alberta Sono. And
I'm Jean Deschamps from the University of Montreal in Montreal, clearly.
there we go. Excellent. So we were chatting about having another black box discussion because we felt like this topic in particular was one that is really beneficial, but also kind of mired in some complexity here and there. So our target audience really is on those people who are really honing their skills as more advanced critical care or acute care echocardiographers. Hopefully, a broad overview of this spectral Doppler technique with a very specific focus on the use of pulse wave Doppler in terms of our modality of choice. So, you might wonder, why would I want to use Doppler for this technique, and what's the importance of using this for cardiac output? And Jean, from your standpoint, how often are you using this in your ICU?
So I use it extremely frequently. I'd say I do it on every echo I do, and I probably do it every day. There's a bit of a variation in when I use it. I do a lot of cardiac ICU, which I use it all the time, and a lot of general ICU where I probably use it a little bit less. I think it's a very helpful method, and it's probably to me more helpful than knowing the EF of the patient because it's a lot more dynamic and it's a lot more telling about the hemodynamics of the patient than EF is. Whereas EF can be chronic or acute, the output that you have that's reflected by Doppler actually tells you a bit more about whether or not it works with the patient's condition.
Yeah, I mean, I would agree. Like if you do this well, if you acquire it well, a nice clear angle, nice good waveform, you have a really solid objective measurement of what that output is like, right? So I think that's one of the main benefits is just the fact that it's reliable and accurate, and if you can do it well, then it is really helpful at the point of care. And of course, I use it quite often for differentiation of shock types, for example. Obviously, it's less invasive, and you can trend it really easily, much more than say an ejection fraction can, for example. Certainly, there is more of a time input in terms of learning the technique, but if it's a value in terms of the actual input versus the actual benefits yielded.
Yeah, I totally agree. And one of the things that people will say, well, if I put a pulmonary artery catheter, then I have much more ease to get my numbers and might get better numbers. The thing is a P catheter has the same type of learning curve. If you don't know how to use the numbers, you're going to get into trouble. And I would argue it's some way a pulmonary artery catheter, if you use it with all the values that's involved, it's probably a bit more of a learning curve than getting a VTI done and using it, because cardiac output, the actual number you get, means a lot more to most people than cardiac output, SVR, and so on in the context of a patient clinically assessed. The other thing that I use it as well is when I have a P catheter and I'm looking at a number, I'm like, I'm not sure if this is right or not. It might be TR or something like that. I use it to calibrate my P catheter and see if it's accurate or not. If I get two numbers that are similar, then I kind of know, I validate my number of my P catheter, and that makes it more useful later. So that's another way I've used it on a pretty frequent basis, I have to say, when I think about it.
That's awesome. So obviously, our focus here will be on pulse wave, which the modality itself, we can see here on image left with the sample volume box and the outflow tract. This modality of pulse wave Doppler is range specific. Obviously has a max velocity approaching 200 centimeters or 2 meters per second. In terms of how it's acquired, and spectral Doppler is really just the kind of graphical form of color Doppler. So I think that just to illustrate there for those who are learning this modality for the first time, this is how we typically talk about spectral Doppler.
Yeah, and one of the things I think we need to mention about spectral Doppler in a way is because it's a single line over time, the temporal resolution is much better. The speed also you can resolve, it's much higher as well in color, because color is pulse wave in multiple spaces in a box. So it's a lot more processing power, and your resolution and your speeds is going to be not as precise as you can get with a spectral Doppler.
But of course, first, before you can even talk about these spectral Doppler, you need good views. I think this is probably the thing that should be emphasized most, is you need a really solid apical 5 chamber if it's transthoracic. You need to look at that angle of interrogation of that Doppler probe being less than kind of 15, 20 degrees in terms of from the angle of flow. And if you go over that, you are going to underestimate your outputs. And I think that's certainly one of the biggest caveats. Jean, do you have any perspective on that?
Yeah, I think so. We were discussing before this video because we talk a lot, as you may have noticed by now. But you were telling me that you've heard some people say less than 30 degrees. I think the distinction becomes important because when you do this in a formal echo lab, when you pass 20 degrees, which is what most textbooks recommend, this is when you start introducing significant error for your cardiac output measurement, your VTI measurements. The less than 30 probably is fine for most of our critical care applications because we don't need as precise of a number. Why don't we need as precise of a number? Is because we are not looking at qualifying if a patient needs surgery or not, if a patient needs a valve replacement, which is what the job of the echo lab is. Our job is not that, it's to estimate a gross cardiac output with VTI, which means that the precision of a couple of like 100 cc's or so probably is not the major thing in what we use it for.
Certainly with transesophageal echo, we can use other views shown here. On image left, we have a transgastric long axis with the outflow tract around 5 o'clock. And this angle will occasionally offer you a very helpful angle of intercept there for that flow. And on the right, we have our distal transgastric, which you can see here. The angle is very, very strong in terms of interrogating that flow.
Yeah, and I fully agree. And I think that the thing that people don't realize is this is a beautiful deep transgastric image. It doesn't always, and I would actually agree with, rarely looks that good when you get it done.
I cherry picked this view just for you, Jean. I was like, I need a view that will make Jean blush.
I would argue that sometimes the view on the left, which is a transgastric, is sometimes a bit easier to get. And I will also argue, the final argument here is that honestly, it's actually easier by TTE in a lot of patients to get the proper angle and alignment to get your VTI. So yeah, use your TE probe if you have difficult views, but if you have good views, don't drop a TE probe down to get a VTI. You're going to be so sorely disappointed.
And then, one of the questions that comes up a lot is, where do I place this sample volume box on the pulse wave Doppler? And I guess, I commonly place this in the outflow tract 1 centimeter from the valve. That's proximal to the valve, but this is this can be placed somewhere else. But Jean, do you have a perspective on this?
Yeah. So I think that's the important thing when you put your gate for your pulse wave Doppler is to put it within 1 centimeter of the aortic valve annulus, with the basic principle being that you want to put your gate where you're going to measure your actual annulus in the outer view, the parasternal long view. It is very hard in the apical view to put it exactly where you're going to go. So anywhere within 1 centimeter is fine, and that would be also textbook answer and textbook supported.
I've also heard, some people have advocated for placing it at the basically aortic valve leaflet insertions. That way, it's a little more standardized. Once we place this and we press, Doppler, it gives us this beautiful waveform on the right side. And obviously, we have some ECG gating here. We can see in systole this nice, beautiful spectral envelope that has this scalloped where it's kind of dark in the middle and kind of brighter on the outside. So it's clearly nicely placed in the envelope here. We trace this VTI here, and it gives us a number. And you can see here on the left here, 17.2 centimeters. And this VTI has actually been studied to correspond amongst a range of body sizes, and normal VTI is around 18 to 22. But do you want to talk about this measurement here, Jean, a little more?
Yeah, so the VTI is in the name of velocity time integral, meaning that you take all the velocities that you pulse over time, you do an integral, and it gives you a centimeter qualification. And if you use that value and then you multiply by the cross-sectional area of the location where this is taken, you end up with a volume, which is what we're looking at. So the VTI itself is not a volume, but multiply with the cross-sectional area it is. And so that becomes the stroke volume, which is what we're interested in. Another point, I think, before we move on from this specific thing, the normal VTI across a range of body types and size of 18 and 22 is fair. Although with age and extremes of body weight, you do end up with VTIs that can be different. I'm talking specifically of elderly small ladies can have a VTI that's actually much lower
Yes.
than that and would be normal within their normal body size and expected pathologies at their age in terms of cardiac structural disease.
Okay, so let's move on here. So here's just an example of a normal VTI. So we're just gonna watch here. You can see that initially the angle was off, and so there's been some manipulation here for this 5-chamber just to optimize the angle of interrogation here. So that sample volume box is a centimeter from the aortic valve. You can see the spectral waveform here. The baseline is adjusted upwards. That way we can see the full spectral envelope. And obviously the scale is optimized because you want to see the tip of that output. Now, to trace the VTI, we typically will start at the baseline. So you can see here the cursor will be drawn to the baseline. It will trace upwards, making sure you're following it closely. And you trace it all the way back down to the baseline again, just being careful not to be overly inclusive. And we can see here that our VTI is 17.7. So I think, this obviously is a nice example. Patients in sinus rhythm. If they were in atrial fibrillation, they may have some variation from beat to beat, but I think that's a good example there of getting our VTI in real time. Now, as you kind of alluded to, this VTI is helpful alone, but it also can be transformed to cardiac output. And I think this is the part where there is lots of debate, because the question always becomes where do you measure? So obviously in our Pearson long axis, as you kind of mentioned earlier, it really depends on where that sample volume was placed. If it's placed in the outflow tract within a centimeter of the valve, then that's where you should be measuring. And if it's placed at the aortic valve annulus, then you should be measuring the aortic valve, obviously in systole. But you really want a high quality Pearson long axis view. And I think there's a lot of emphasis on making sure you can see that endocardial border really well, right?
Yeah, and you also want to see the leaflet insertion really well. And the reason why we use a Pearson long view, and you shouldn't really use it in an apical view to measure LVOT, is because of the way ultrasound functions. You're going to get way better resolution and less artifacting of side lobe artifacts in this view, and you're going to get a very nice line to be able to put your marker and measure. The second point I think that needs to be too is measure where you would put your VTI, your pulse wave Doppler gate. Now, as we said before, it can be quite tricky to do in an apical view and know exactly where you're at. I would advocate instead to always put it in a standard way like you would do in a cardiac echo lab, which is at the insertion of the leaflets. Because at least that way, from person to person, you would have the same, or as close as possible, same LVOT diameter measurement, which might in the end make it more reliable than measuring exactly where you think you put your pulse wave Doppler gates.
So obviously, once we get that diameter back, we cut it in half to make a radius, right? And we get this CSA or cross-sectional area. And we do this kind of whole pi r squared thing to truly make up that one-dimensional stroke volume into really a kind of three-dimensional bolus of blood. And of course, if you were to, shoot from the hip, you just say, well, the diameter is probably around 2, which is obviously a big assumption. But if diameter is 2, radius is 1 squared times pi equals 3.14. And you could times this by your VTI to roughly give you a stroke volume. Obviously, that would be baking in a lot of assumptions. And that R squared can really double down on any error you make in that radius measurement.
No, absolutely. And I think you're right. In reality, if on a day-to-day basis, I can't say I always measure it because I'm not looking at an extremely precise cardiac output. I'm looking at, is it really high or is it really low, right? And so that measurement, we know for a number of reasons, already inaccurate. If you look at body surface area and size estimations and rules for LVOT diameter, you end up realizing that most people are around 20 to 22 millimeters. There are extremes when they have pathology of the aortic valve or very small people, but these people usually see it visually in the 2D and you can adjust for, and you can kind of see these are the ones I need to measure if I want to get something a bit more precise. That would be my argument in terms of measurements.
Just have this diagram here to kind of illustrate why this problem happens in our measurement. And especially the Pearson long axis, it can really be impacted by how you're acquiring that image. And so that's, as we kind of alluded to, it's one of the big concerns I have with making this measurement is just the potential error is so easy to do. But this is one of the problems with conversion to cardiac output. John, do you want to explain more on this?
Yeah, so this is exactly what we're discussing, is that we all believe the aortic annulus is round. It's actually an ellipse. And because of its ellipsoid nature, the measurement can vary as much as between 2.4 centimeters to 3 centimeters in this specific image. That gets even worse when some people have aortic pathologies and they get into more dilational situations. But even the normal aorta, you can have a wide variation depending on how you measure and angle it. And because you're doing a 2D measurement in parasternal long axis, you can easily change where you're cutting and have a big impact into the total diameter that you measure, which can have, because it's squared, a fair amount of difference into your cardiac output as well. The CT scan is one of the probably best ways to measure annulus, and those are two good examples of that. TEE by 3D can also allow you to do similar measurements and adjust, but in 2D TTE, you're kind of bound by the view you have. The other thing to notice, if you look at the top right image there, is that calcifications in the annulus and the actual leaflet can make quite hard to know exactly where to put your marker. And that can have a significant impact also on the dimension. So pay attention to that if you're trying to trace your LVOT.
There's been more than a few studies now looking at using cardiac output in terms of against the gold standard being transpulmonary thermodilution. So I've just highlighted one here. That's one of the original studies by Huntsman and all, looking at this against more invasive measurements. And obviously in this case, they had a high degree of correlation with a high R value of around 0.89, 0.9. And a more recent study in 2019 looked at comparing a number of studies, basically comparing cardiac output by Doppler versus pulmonary artery catheter, and showed that essentially they often revealed the same findings. Echo output may be slightly higher, but it's minimal. It's minimal.
Yeah, I agree. And like I've done this, as we've alluded to, this calibration and kind of comparison between the two a number of times. And sometimes it's quite stunning how close they are. And you almost can't believe it. You think you've tweaked numbers somehow, but no, sometimes it'd be that precise.
As you mentioned too, there's obviously caveats. AFib, they can have variation in stroke volume, as you see a variation in atrial kick, and you need to often average several VTIs, like 5, which can take some time, as you've seen here, tracing out several VTIs, and then angle of interrogation can be a pain. If you're taking the same measurement repeatedly, then having less than 30 degrees can be acceptable, especially if you're imagining peak velocities. That's a little more helpful. Fantastic. Yes, and then obviously, you're measuring forward flow. So if you have a large amount of regurgitation, then really you're not measuring a true stroke volume because you have diastolic backfilling. Because some of that blood that goes out will come back in. So that's really you have to be very careful in that situation, and we'll talk a bit more about that in a short while here. So I went ahead and acquired this, but what are your thoughts on this waveform, Jean?
So the first thing is when you look at this waveform is that your angle is very, very off. And that would be, I would consider, past what should be allowed to properly have a good pulse wave Doppler VTI calculation. You notice that there's an issue even just looking at the waveform, because as you notice on the side as you're coming up, it's quite narrow. And then when you get to the actual peak, it becomes quite wide. It does in the normal tracing become a little bit wider there, but this one is a little bit flatter and it's not peaky as it is normally, and it's definitely quite wide. You can see it's almost like more than a third of the total waveform is this gray kind of contour. That to me is usually a sign that there's something wrong with the signal, and it often is the axis that you've used.
Yeah, I mean, here's another example that's I think obviously a little higher quality here. We can see our angle of interrogation now. Again, we're going to place it in the outflow tract, a centimeter from the valve, and we can see another waveform. Our LV function in this case was depressed, and so we'd hope for a congruent standpoint that our VTI would likewise be impressed. If your cardiac output is extremely poor, it can at times be hard to find the actual stroke volume, make sure you've identified it and not just some of that baseline fuzz. And so that's where ECG gating can be really helpful to make sure you actually are tracing the proper stroke volume. So in this case, we have a VTI of 8.7, which really does correspond to that poor ejection fraction. I think that's kind of helpful to have that symmetry in your findings.
Yeah, and the wave usually when you have a low stroke volume is actually more flattened and kind of spread out, like a cookie that's been smushed in some way. And that's just because you're ejecting for a longer period of time. So this one is an interesting tracing because you're seeing that you're not capturing your VTI at every beat, and that's probably because you're getting lost of your window at times. The other thing that you notice is that you don't have that dip in the middle of darkness with a clean envelope, thin envelope around it. And that's probably because you're a little bit too close to your aortic valve and you're catching that kind of turbulence and acceleration that you would catch normally in a CW tracing. That tells me when I look at this tracing that I'm probably a little bit too close and I should get back. What you're looking for is the perfect balance between that narrow kind of very echogenic band around with the dark notch in the middle. You're also trying to look at your valve opening and closure, which you can sort of see here on this tracing above the baseline, especially the closure one, where you see a little peek back of a small amount of flow that comes back as you quickly close your aortic valve. This is also why usually when I trace a VTI, I don't put my baseline all the way to the top because I want to see a little portion above it to help me direct where I'm gonna meet the baseline when I'm tracing.
That's for sure. So one of the things that we talked about earlier on was that in aortic regurgitation, we are measuring forward flow, but of course the problem is that you get a lot of regurgitation. So as you can see left here in the spectral waveform, you have that regurgitation on continuous wave Doppler that's above the baseline during diastole, and so a bunch of blood goes forward. But of course, all the blood comes back and has to be re-ejected. So, what are your thoughts? So we have a VTI here at 24.6. Jean, what do you think about this this set of waveforms here?
Well, first off, it is actually the stroke volume for each beat coming through the aortic valve, but it's not the total forward stroke volume to the rest of the body, because part of it comes back and forth, as you alluded to. What's interesting and important to know when you see such a high VTI and you have AR is that only holds true as long as you have a ventricle that still has a decent EF and a decent contraction. Why do you have such a big VTI is because your LV dilates, maintains a good ability to eject, so it's able to eject a lot. When you have significant AR and you see VTI that's within normal for what we described before, you got to start asking yourself questions about this because it might be that your LV is failing and is no longer able to generate the amount of stroke volume that should be done with a normal LVEF and a dilated LV.
And of course, finally, just to round things out here, we have a case, a young gentleman who was stabbed in the chest in the RV who had some obvious tamponade. And, this is just an example here of that variation in stroke volume in VTI that you can see in tamponade. So this patient's in sinus rhythm. That way, the VTI waveform should be identical from beat to beat. Now, of course, pulsus paradoxus, the clinical findings, and some of the mitral and tricuspid inflows can also be helpful. But in this case, the patient had a large pericardial effusion, and it was quite obvious they needed to go to the operating room. So this is more just for a point of discussion rather than a point of utility. So just to kind of round things out here, we've talked about pulse wave Doppler, we've talked about spectral Doppler, we talked about how we use the waveform, how we critically appraise the waveform, and how do we trace it, and then finally, how we actually interpret that waveform in the context of the patient. Is there anything else you want to talk about, Jean, from this standpoint?
One last thing, and something I want to throw out there, is looking at the evidence of where to use VTI. And use VTI, it's been mostly studied in sepsis in terms of volume response to see if your VTI goes up, then you might be volume responsive. I would argue, however, that you probably should multiply about heart rate as well, because that would also change dynamically depending on the manipulations you do hemodynamically to your patient. And the product of those two might be more reflective of what your actual manipulation is doing if you're looking at a percentage change over time. Classically, we look at a percentage change of more than 12 to 15% to manipulation
Yes.
in response to the VTI increasing. But that probably is going to be even better if you multiply by heart rate, because you'll get also the heart rate response involved, which is part of the cardiac output.
I will say one of the issues I should have mentioned with VTI alone is that when you look at higher heart rates, the VTI can become less accurate. You know, a heart rate of 130, for example, 140, that's getting really quick. And from my perspective, that VTI becomes less standardized when you start hitting high heart rates. So that's a really good point.
Yeah, most people would say
Um,
above 120 is not standardized. It's certainly not studied in at least the outpatient echo lab.
So I actually just tracked down this review from Pablo Blanco. Just a great review for the kind of the general um, overview of using spectral Doppler in VTI, and covers some of the caveats and kind of how it's done. So, you know, for those who want to read more, I would take a look at this paper. I think it's really well written, and I think it kind of gets to the point of the issue. So, yeah, I think that's really it for now. That's our black box discussion. I want to thank Dr. Deschamps for joining me and kind of going through this and teasing it apart. And we just want to say thank you for watching this.
Thank you very much.
Jean?